That X-ray is backwards, man. uh, well, what are we looking at? Was the next question. We're looking at a backwards X-ray, apparently. My bad. I need to flip that, don't I? Yeah, I should probably start doing that. All right, let's turn down Bieber a little bit here, shall we? Think with Justin Bieber. He's an interesting character, but he makes some good music. I don't. Yeah, I keep listening to it. All right, put up a chest X-ray earlier today, and then I asked, "Is this normal?" Because I'm asking the question. It's case of the day. You probably already have a tendency to think that it's abnormal. You are probably already dispositioned to say, hey, you know what? This is something going on. He's trying to trick me. He's trying to pull a fast one. I should be looking real hard at it. Two things that I want to go over with today's chest X-ray. One, the actual finding. What really was the pool noodle? Yeah, I know, that was funny, right? That's yeah, KUBs. You can get some weird stuff. Is it backwards or oh yeah, yeah, no, it's just the backwards screen on Instagram. But we can talk about one day situs inversus. There's different types. Situs inversus totalis is, and situs inversus is seen with cardiganers. So we can't talk about that one day. That's a fun topic. But twofold for today's chest X-ray. One, I wanted to talk about. You need to know what a normal chest X-ray is. You need to know that what normal variants can look like, and you need to be confident to call something normal when it is normal. Next question. Someone's definitely studying for step one. I know, right? Cardiganers for the yeah. That was definitely a step one. That was a while ago. I gotta think about now. There's cardiganers, yeah, and there's a ciliary dyskinesia. Oh man, I gotta go back to a while ago. Yeah, we think zebras. I try not to think zebras. I'm thinking normal, 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 and normal variation, and common abnormal, and then I'm going to zebras. But zebras, man, they make for good cases, so that's why I'll start posting some zebras, and if you guys get them, I'll shout you out. I'll do whatever. I mean, if you start getting the zebras, because they can be tough. So going back to today's chest X-ray, know what a normal looks like. It was a normal chest X-ray. There was nothing that was acutely wrong with it. Sure, the patient may have, had a smoking history, whatever. There's just some, old person lungs. Otherwise, there's nothing acute with the chest X-ray. But again, I want you to be comfortable with calling a chest X-ray normal when it is normal. You need to be comfortable with that. Somebody asked me for a lateral view. I provided the lateral view, and we'll talk about the lateral view. Make sure, certain areas that you want to look at. The one variation that I did want you to focus on, because it is a normal variant, but if you have not seen this before, you may be confused and be worried about something else. Okay, so the normal variation. My bad, this is flipped. This is not cardiganers. This is not situs inversus totalis. This is just a flipped screen. So this is the variation that I want you to look at right here. A lot of people, there were a couple of people that actually got it right as to what it was. A lot of people focused on it and said, you know what, there's widened mediastinum. There's something going on with the superior mediastinum. There's something going on. What, anybody shout that out? Does anybody know what that is? Not the radiology guy. Obviously, he knows what it is. Anybody else, though, know what that is? Let's go look at it again. What is this right here? Anybody? This is a classic location. Once again, this annoying thing is flipped. It should be the other way around in your screen when you're looking at it, but it will be on the right side of the patient. If you ever need to figure out which side is the right side as far as these flipping whatever, here's the aortic notch, and it's going to be on the opposite side of it. Pneumomediastinum, that's a good guess. It's not pneumomediastinum. We can talk about pneumomediastinum at one point, and we can talk about mimics of pneumomediastinum, what it is, why it happens. It's a common topic about Boerhaave's and that kind of stuff. So we can talk about that at one point, but it's not pneumomediastinum. Anybody else know what it is? Or anybody's joining right now, we're talking about this guy right here. Once again, normal chest X-ray. I passed it. I said, he's good to go. Off he goes. Cervical rib, not quite. So what this is an azygous lobe. This is an azygous lobe. You will see this quite commonly. Now that you know what it is, you will look for it, you will see it, you will move on in your life, and you will not care about it anymore. This is an azygous lobe. But if you have not seen this before, it will cause you issues. You will question it. You will ask for a lateral view. You will get a CT scan, and you will keep continuously trying to work this up. Have you not seen this before? This is an azygous lobe. Basically, right here is where the azygous vein is, this area right here. And this is an embryologic thing that the azygous vein kind of gets displaced a little lateral, and then it creates this kind of like fissure right here. This right here, it's not a true accessory lobe. It doesn't actually have like a bronchus going to it, like its own bronchus. So it's not a true accessory lobe, but it is completely separate from this one in the sense that there is parietal and visceral pleura between these two. It actually has a set of parietal and visceral pleura on this side and then a set on this side. So there's actually 4 layers separating these two right here. Why am I stressing on that? Because really, who cares how many parietal and visceral pleuras there are, right? The only reason that I want to stress this upon you is if first of all, if somebody's interested in an IR, you're going to be doing a lot of lung biopsies, okay? When you do lung biopsies, you do not want to cross the pleura more than once. You want to park your guide needle right before, let's say, I don't know, I'm using something in midair right now. Let's say the nodule is right here, okay? If I'm getting my guide needle, this is called a coaxial approach. Coaxial approach means I'm gonna get a guide needle and park it right before that nodule. And then I'm gonna take the stylet out of the guide needle, and then I'm gonna actually put my biopsy needle through there. So you see what I'm doing? If I have to take 5 biopsies, I'm not taking the biopsy needle back and forth out of the lung because I do not want to cross the pleura that many times. I want to cross it once with my guide needle, and then through there, take 7, 8, 9, who cares how many, whatever biopsies I need to take. Whatever, safe for the patient, obviously. That's how many I wanna take. So that is, oh yeah, that's what I was getting at. So you don't want to cross the pleura that many times because what can be the consequence of crossing the pleura too many times? Anybody, go for it. Anybody? What's the one thing that you're worried about most when you do a lung nodule biopsy? Or you place the central line in the right IJ? Or you did a thoracentesis? Why are you always getting a chest x-ray afterwards? Because you're checking for a pneumothorax, okay? So the more times you cross the pleura, the more chance of getting a pneumothorax there is. That's the reason I say that. If for some reason you had a nodule way over there or something like that, you don't want to cross that if you can't, or if you can help it. That's the same for any other fissure, minor fissures, all that stuff. Whatever fissure it is, you want to be very careful and you don't want to cross that. Here's a quick side note. Everybody's guessing pneumothorax. I love it. The radiology guy, it looks like he just passed gas. I'm not really sure. No, I get it. It's probably like a tension pneumo or something, right? So if you cause a pneumothorax, and I'm asking the question, so obviously there's probably more to the answer. Does every patient need a chest tube? The answer is no. Thank you. Well played. Not every patient needs a chest tube who gets a pneumothorax. There are plenty of people who are walking around with just a pneumothorax just because. And the reason I say this is because I've had multiple patients who have come in at one time. I was getting ready. I think I told this story already, you guys. Maybe I'm boring you at this point. But the patient came, she sat down in the CT scanner, she laid down, they did the scan to get ready to do the biopsy. That's our pre-scan. So then I walked in and I said, all right, let me see where the nodule is. I look at the pre-scan and her lung was completely down. Like it was gone. It wasn't even there because it was so like squished down from the pneumothorax. I looked at her, she's sitting totally fine. She's completely normal. I guess she was just walking around like that. So people can walk around with a pneumothorax, but here's the caveat now. When we do a lung biopsy, when we do a chest tube, whatever it is, or not chest tube, when we do a lung biopsy or a thoracentesis, we're going to get a chest x-ray right after we do the lung biopsy, immediately after. We're going to say, okay, chest x-ray looks pretty good. Then I'm going to say, hey, 2 hours from now, I'm going to get another chest x-ray. And then I'm going to compare those two because now I have an initial chest x-ray, something to compare to. And then 2 hours later, I'm going to say, well, you know what? The pneumothorax was about that big on this one. 2 hours later, it's about that big. Even if it did get that big, I'm still looking at the patient's vitals. If that patient's blood pressure is stable, if he's not tachycardic, if he's not short of breath and he's just sitting there eating a ham sandwich or something, whatever, all right, you know what? Maybe he doesn't get a chest tube. If even it could be the smallest little thing, but if they become symptomatic, if he's tachycardic, he's hypotensive, he's short of breath, he's on nasal cannula, non-rebreather, all that good stuff, well, he bought himself a chest tube. When we think of chest tubes, you may be thinking about these big old surgical chest tubes that are like 30 French. They're big guys. They go into the side right here, mid-axillary. It's called the triangle of safety, if anybody wants to talk about that. I still remember this from intern year. Why did I place chest tubes intern year as a medicine resident? Because I was proactive and I got out there and I asked every single surgical resident if they didn't want to put the chest tube in, let me do it. I placed a lot of these large bore chest tubes. Now in IR, we're basically putting pigtail catheters, little 8 French, 10 French drains. They're drains, and you're draining out the air. So they're little tiny guys. We can place them anteriorly, second intercostal rib, kind of mid-clavicular, right around here. We can place them here. We can place them on the side. We can place them in the back. We can place anything wherever we want, right? So that's the kind of chest tube that we place for these patients. It's so much more less intrusive. The patient's not as uncomfortable when they're sitting up on the floor. They don't have this huge hose sticking out of them. That's the kind of chest tubes we place. Usually we place it, they go up to the floor. We suck out the pneumothorax overnight. We get another repeat chest x-ray in the morning. We clamp the chest tube. The pneumo does not come back. We take it out, off they go. A lot of talking right there. Anybody want to say something before I go into the lateral view? Anybody? All right, you want to go into lateral view? Let's do it. All right, so I asked, did you guys, or somebody asked, can we have a lateral view? I provided the lateral view. Ooh, somebody's got a long question. If a patient has an uncomplicated pneumothorax, does it get worse if he flies? I keep having this dream that I'm the only doctor on the plane and a patient develops a pneumothorax. Oh, man, that's a question. Anybody have an answer to that? I don't know. It's a pressurized cabin. I don't have something that I've not really thought about. I can get back to you on that. All right, let's go into the lateral view. So here's the lateral view. Anything going on. The things that I want to stress on the lateral view. This is the heart. You want to see a nice dark area right here. That's beautiful. What happens if you don't see a dark area right here and you see the sternum actually concaving in like that? You got to think about Pectus deformity, okay? Pectus deformity is when the sternum kind of indents in like that. So you won't see this dark area back here. You want to see this retrocardiac, this nice dark area back here. All these hilar structures, that's normal. You just have to get used to. You have to see a lot of them to know what is too chunky there. And then you want, remember, you want to see the spine going from bright to dark down. That's normal. Remember what we called if this spine went from bright to dark and then back to bright again? That's the spine sign. Apparently somebody wasn't creative enough to come up with like the, I don't know, the centipede sign. I have no idea. But they went with the spine sign, appropriately named, right? Let's go again real quick, just a real quick recap. How can you tell which hemidiaphragm is on which side? Do not tell me. I actually just did the medicine talk today. I tried to live stream it from you guys. It didn't work. I did not have internet connection at that point for some reason. I have no idea why. But this is something that I did cover in that talk today. How can you tell which hemidiaphragm is on which side on a lateral view? Please do not tell me stomach bubble. Please do not tell me about the height of the hemidiaphragms. Yes, those are both good guesses, and both can probably get you the answer, but there may be times that cannot get you the answer. So I want to tell you the definitive way of getting the answer. Look at both of them go back here. Beautiful, beautiful, right? We don't have a pleural effusion. Remember, pleural effusions can hide back here, and on AP, you won't see it. I went on a side note again. So here are the hemidiaphragms. They're going all the way back here, and then they're coming all the way up. Look at this one. This one stopped right here. Why did this stop? And I can't track this one all the way to the anterior aspect. Why? Because the heart has now silhouetted out that hemidiaphragm. You have too many opacities that are abutting each other. So therefore, which side does the heart sit on? Everybody knows. So that's going to be that hemidiaphragm. This hemidiaphragm over here, look, it's going to go all the way. I can track it all the way anterior. So which side is that going to be? That's how you tell which hemidiaphragm is on which side. Again, stomach bubble is not going to be always reliable. The height of the hemidiaphragms are not going to be always reliable. How about normally a hemidiaphragm, which one, the left or the right, should be higher normally? Think about it, give you a couple of seconds. The liver sits on the right side. Again, this is flipped on the screen. The liver sits on the right side. Okay, so the liver's big, big, big. It's gonna raise the hemidiaphragm up. So normally the right hemidiaphragm should be higher than the left. If the left is higher, then you need to start thinking about reasons as to why it is higher. I did not provide the CT image for you guys on my stories. I'm about to provide it right now, just because you guys are awesome. Here we go. I talk so fast, my mouth can sometimes not keep up with my brain, because I'm just going. So, and that's why I drink a lot of water when I do this. But I'm just firing off the top of my head right now. All right, this is the CT that I provided, or I'm providing now. I did not provide before. So you can see this is the azygous lobe right here. This right here, this is the fissure right here, the azygous veins right here. And I provided the soft tissue window right here to see where the actual azygous vein is, which is right there. Here's the azygous vein. Usually it's hugging, it's real close. You don't see this gap of air between, or lung, I should say. It's hugging the mediastinum right here. So this is the azygous vein, and azygous lobe, fissure right here. Remember, multiple plural right here. Don't cross this thing if you can't, or if you can help it. I think that's everything. I covered everything. So again, just to recap, I wanted you guys to look at the chest x-ray, and I wanted you to get good with seeing what is normal, and I want you to be comfortable with what is normal. I know a lot of people have not seen too many chest x-rays, so that's hard to do right now, but that is what I am here for. I'm here to help you figure that part out. I got CT correlate for you guys now, so now you know what an azygous lobe and azygous fissure looks like. Now you know what to do on a lateral view. You guys are set to go out into practice. Yeah? All right. That's a sign of intelligence. You train your thoughts are faster and talk faster. Wow, this is a really interesting case. Hey, thanks. I try to make it actually really interesting. I appreciate that, by the way. I try to make it interesting for you guys. There's always a gem or a nugget in every single case there is. If anybody ever tells you this is just a general medicine or a general life thing, I don't care if you're a banker, a radiologist, a flight attendant, I don't care what you are. Every case is not the same. Every person is not the same. Every patient's not the same. Every x-ray is not the same. There's always something to learn from it. If me as a radiologist, I will look at 50 chest x-rays a day. 47 of them will be completely normal, nothing really to report. Some of them will have some stuff, but out of those 47, okay, it's more like 47 out of 80. I don't know, whatever the number is. But out of those 47, there's still something that I'm looking at that I'm going, damn, did I notice that before? Was that supposed to be there? Is that normal? I'm still questioning that. I'm still learning from it. Even somebody, when you're doing procedures in IR, surgery, whatever you are, if I, as a radiology resident, and I go up to a junior resident and I say, hey, do you want to do the PICC line? If they like gasp at me and go, oh, PICC line? Who wants to do a PICC line? Do you know how hard a PICC line is? If you've ever tried to do a PICC line and hit a vein that is that small, if you can hit that, you can nail the IJ in a second. So every case, no matter how small or large it is, you have something to learn from. You absolutely do. I want you to take that home, please, especially in medicine. I don't care if you got your 30th DKA patient of the week. There's something to learn from that. Please take that home. Whoo, ranting. Sorry. Really nice. It's my first time on here. Glad I found you. Hey, thank you. USMLE Dreams. I appreciate you checking me out. I want to just keep doing this. You guys tell everybody. Tell absolutely everybody. Radiology guy, nice done, bro. Hey, I appreciate it, man. All right. You guys good? Are we good? Call it quits for today. Pick it up tomorrow. Do whatever. We'll see what it is. Awesome as always. Thanks. I appreciate you guys. We'll pick it up tomorrow. Till next time.